Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Fouad AlSaleh. Today, inshallah, we're going to talk about the intercostal space and diaphragm. First of all, we're going to talk about the intercostal space, which is the space between two adjacent ribs. We know that we have a rib cage and there's a ribs. So between the first and the second rib, there is a space between them. This space we call the intercostal space. In this space, we have two things. We have two structures. We have the muscles and we have the neurovascular bundle. The muscles from superficial to deepest, we have the external, internal, and innermost. As you can see here, external, the most superficial, and the middle, internal, and innermost, the deepest one. The neurovascular bundle, we have the vein, artery, and nerve. Type. What is the function of the intercostal space? What is the function of the rib cage itself? Two functions: support the thoracic wall, protect it and support it. Second thing, which is the facilitate the breathing movement. We have a muscles surrounding the lungs. So it's gonna be obvious, it's gonna expand or it's gonna squeeze the lung, which is gonna maintain or help in the respiration movement. A good note to remember here, which is most exposed or vulnerable structure, is the nerve and the posterior intercostal artery. As you can see here, the rib itself is not cover all of the nerve, so it's gonna be most exposed. Now we're gonna talk about the intercostal nerve block, which caused by the local anesthesia, which is used clinically for pain relief in the thoracic procedures. If we have a surgery and we need to numb this area, we're gonna use the local anesthesia and by blocking the nerve itself. In the human body, there's specific skins or area, we call them dermatomes, and they supplies by more than two or more nerves. So when we need to make sure that we numb this area full, we need to inject two nerve for the same area itself, and then we call the overlapping plugs to ensure a complete anesthesia of skin area. It's often necessary to block two adjacent intercostal nerves. Why we need to block two? Because there's dermatomes, one specific area which is supplied by two different nerves. So if we need to make sure that they are numbing for the patient not feeling pain, we need to inject the local anesthesia twice for two different nerves. Previously, we have space between two adjacent ribs which contain muscles. Type Fouad, what is the type of these muscles? We have three types of these muscles, from superficial to the deepest: external, internal, and innermost. First of all, we have the external. External, which is the superficial one. As you can see here, the fibers itself runs downward and forward. It's going like this. So it's going to downward and forward in the same time. And obviously it's going to extend from posterior in the rib to the costocondylal junction interior. So it's going to go from back to in front. And this extend is going to help when it's contract, it's going to elevate the rib. هترفع الرib, so it's going to give more space to the lungs to expand. And this is obviously is going to help in inspiration itself. The second type of muscles is going to be the internal intercost. Internal intercost, well, as we said, is the middle layer, and it's going to be the opposite of the external. The fibrous is going to be down, but in backward. So as you can see here, this one is down forward, this one is down backward. So it's going to go up like that. That means they're going to extend from interior to the posterior, the opposite. It's gonna from the it's gonna extend from the sternum, which is interior, to the rib angle posterior, and this is gonna what? It's gonna depress the rib, which means that, as you can see, it's obvious because if it's going back, so when it contract, it's gonna squeeze the lungs, so it's gonna decrease the space, so it's gonna force expiration, so it's gonna help you with expiration to let the air go out. We're now going to talk about the last one, which is the deepest layer, which is the deepest innermost intercostal muscle. As it's obvious, it's going to be parallel to the internal intercostal muscle, and it's gonna assist in the rib depression. So it's gonna help the internal intercostal. These two muscles, they're gonna help in the expiration, and this muscle is gonna help in the inspiration. Now we're gonna talk about Flail chest, which is very important clinical case in this lecture. It's a severe injury resulting from multiple ribs fraction, means two or more adjacent ribs, they are broken from more than one spot. So they are broken from two sides. That means they are detached, so they're gonna move freely. Becomes detached and move freely. And this moves we called it paradoxically respirations, يعني تناقض, يعني always the opposite as you can see here. So it's always inward during inspiration and outward during expiration, and this movement is abnormal. As you can see here, this is the flannel chest, this is the ribs that it's broken from both sides, so it's freely movable. So when you are expirations means that the rib is gonna be inward, but as you can see here, it's outward. And during the inspiration is the opposite. It's going to be inward, which is supposed to be outward. So this is a paradoxically movement or respiration means the opposite. And this case is very extremely painful for the patient, and it needs a surgical to fix it. Now we're gonna talk about the diaphragm, which is a dome-shaped muscle separating the thoracic and abdominal cavity. This is a dome shape as you can see here, and it separates the thoracic cavity and the abdominal cavity down. So it's in the middle, and it play a main role for the inspiration. So the function of it is a main muscle for inspiration. The attachments of the diaphragm, we have three attachments. We have the sternum, and we have the ribs, and we have the spine. For the sternum, it's with the xiphoid process. With the ribs, it's with the lower six ribs, and the spine is from lumbar 1 to lumbar 3 vertebra. These are the three attachments for the diaphragm. Of course, as we said, it's in the middle between two cavities. So there's a grave fossils passing through the diaphragm. What is these grave fossils? We have the aorta, and we have the inferior vena cava, and we have the esophagus. Let's go to other slide. Now we're gonna talk about the what is the diaphragm, and what is the structure passing it, and what is the function of it. Type, as we know, diaphragm is a muscle. It need to move to inspiration and relax and contract. Type, what is the nerve that supply this diaphragm? The main and the major one you need to focus on this one is the phrenic nerve. Phrenic nerve is very important one in the two things, in the motor, which is action, and sensory to feel. So the phrenic nerve from C3 to C4 to C5, sorry, is the motor side of the diaphragm for feeling, for the function. And we have the sensory. We have two types of nerves. We have the phrenic nerve, as we said, for the central portion, which is in the middle, as you can see here, the light pink. And we have the lower six intercostal nerves, which is the peripheral portion, which is in the cortex or in the outside surrounding the central portion. And now we have two important things you need to focus on them, which is the phrenic nerve and the vagus nerve. As you can see here in the photo itself, we have sorry, we have one runs interior to the root of the lung. This is the root in the middle. One of them runs interior to it, and one of them posterior of it. So this is the root, for example. One is posterior, one is interior. What is the anterior? What is the posterior? The anterior is the phrenic nerve, and the posterior is the vagus nerve. You need to memorize this one. Now we're going to talk about the openings that or the section passing through the diaphragm and the muscle layer. As we talked about the central tendon, which is the light pink here, it's the apex of dome and fused with the muscle fibers. So it's connect all the muscle fibers surrounding it in one place. So it's going to be here in the middle. What about the structures that passing the diaphragm? We have three main structures. We need to know them: the inferior vena cava and esophagus and aorta. The inferior vena cava, it's at level T8, which is in the thoracic vertebra number 8. And after that, we have the esophagus at T10 and the aorta at T12. And these things, we call them hiatus. Hiatus means the openings in the diaphragm. So you need to understand them. You need to memorize them, sorry. T8, inferior vena cava, T10, esophagus, T12, aorta. As you can see here, this is the inferior vena cava, this is the esophagus, and this is the aorta. Three opening in the diaphragm. Okay, as we said, the main function of the diaphragm is inspiration, the main role. Type how it help, how, what is the thing or what is the steps to help with the inspiration movement. Diaphragm movement, we have two steps. The respiration, it have two steps: inspiration, expiration. And the inspiration, first of all, the diaphragm contracts. This is when it's relaxed, as you can see it. It's like dome shape. When it contracts, it's gonna pull down. So the diaphragm is going to be down. As you can see here in this photo, it's going down. When it's going down, as you can see, it pulls down the central tendon, which is in the middle. It's gonna go down. When it pulls down, it's gonna give more volume for the thoracic, and it's gonna increase it. So the volume up is gonna increase because you are giving more space. That means that you are lower the pressure because they are proportional. So if you are increasing the volume, you're gonna decrease the pressure. So lower in the intrathoracic pressure. So it means that the lung is gonna expand and the air is gonna go inside the lungs. So by contracting the lung, go down, the increasing in the volume, lower in the intrathoracic pressure, expand for the lungs, and the air is gonna go down. And expiration is the opposite, relax, and the central tendon gonna move up, and the same steps but in the opposite. This is when it relaxes the diaphragm. What about the other muscles? They are passive at the rest. The external, as you remember, the internal and the innermost, as we said, they play a very important role in expiration, but in the fourth expiration, not in the rest. So they are passive at the rest, but they active when the abdominal muscle during the fourth expiration. So they are active when you need to force yourself, you need to squeeze more. So that time you're gonna use the muscle. But if it's a normal expiration, only the diaphragm is gonna relax and go back to its place. So that's gonna like not squeeze, but it's gonna go back. So it's gonna decrease the volume and it's gonna increase the pressure and the opposite. Now we're gonna talk about something very important, which is the paralysis. Paralysis of half of diaphragm. In this slide, as we talked about, we have the diaphragm, as we said, and it's supplied by phrenic nerve. We have two phrenic nerve to each side of the diaphragm. But what if injury or something happened to the diaphragm, to the phrenic nerve? It's gonna affect one side of the diaphragm. So this is the process of half of the diaphragm, mean resulting from injury of the phrenic nerve. The affected side of diaphragm moves upward instead of downward during inspiration. So يعني شلل حرفيا انه one side is moving, one side is working, the other one is cannot working because there is a damage in the nerve that supply it. As you can see here in the foot, this is the normal. The both sides of diaphragm goes down, up together. They are together. But in the process, as you can see here, one is moving up, which is normal, and one is going down because there is no nerve supply, there is no motor, there is nothing command it or tell it to move, so it's gonna stay down. So one side is gonna move normally, and the other one is gonna stay. What is it? And this condition, as I said, is gonna be the paradoxical movement. برضو متناقض, the opposite. طبعا this leading to abnormal motion, and can be identified by through radiological tests. So you can identify it by the radiological tests. Now we're gonna talk about the diaphragmatic rupture. Okay, as we talked previously, the diaphragm is separate the thoracic and the abdominal. طيب, what if something like ruptured happened to the diaphragm? What's gonna happen? Let's talk about it. First of all, the diaphragmatic rupture is a tear in the diaphragm, a tear caused by two ways. It's either blunt trauma or penetrating trauma. There's two ways to get ruptured. This injury can lead to abdominal organs يعني الأعضاء اللي موجودة بالمعدة and the abdominal the organs they are there they're gonna herniate it they're gonna go to another side or go up to the chest. So as you can see here, this is the stomach is an abdominal type. As you can see here, the diaphragm got ruptured, so the stomach is going up near to the heart and the lungs. So this is abnormal uh, case. So as you can see here, this is the herniated diaphragm. Okay, Fouad, you said that we have two ways, blunt and penetrating. Type, what is the two difference between them? The blunt is most often when there's a crash, like motor vehicle or car accident, and this is gonna lead to the rupture. And the penetrating trauma caused by sharp objectives like knife or bullet. So as you can see here, this is the blunt and this is a penetrating trauma. Last thing we're gonna talk about it, the main muscle of respiration. Okay, we talked about the intercostal muscle. And we talked about the external intercostal muscle, and we talked about the innermost intercostal muscles. Type, what is, as we talked previously, type, what is the main function of them? Let's go in details just one last time, and we're gonna finish. Main muscle of respiration, as we said, the diaphragm. Inspiration, sorry, is the diaphragm. It's very easy. Contract, so the lungs gonna go, the air gonna go down to, gonna into the lung, and it's gonna expand. So this is the diaphragm. And as we said, the external intercostal, because it's going down and downward and forward, so it's gonna elevate the ribs, so it's gonna give more space to the lungs to expand. This is the external intercostal and diaphragm. Two muscles, they help in respiration. The muscles of expiration, but خلينا نكون just more realistic, forced expiration. So you want to squeeze more, you're gonna use two muscles. They're gonna be the opposite, the internal and the innermost intercostal muscles. In the quiet breathing, as we talked about, expiration results from passive elastic recall of the lungs and the ribcage and the diaphragm. So, as we said, the diaphragm is going to contract, and when it relaxes, it's going to help with the expiration. This is when you are quiet breathing. No need to rush, no need to squeeze more, no need to get more air outside. So, it's going to be normal. So, you don't need to use the internal and innermost intercostal muscles. But when you need to squeeze more, you need to force expiration, you're going to need to use these two muscles to depress the ribcage and expire more air outside. And that's it. Thank you for all your attention, guys. كان معكم فهد. I hope you enjoyed and you find this video helpful. Good luck in your exam, inshallah, or lock in. We'll see you in next videos. Assalamu alaikum wa rahmatullahi wa barakatuh.